Welcome back to my channel, you all. It is Michelle with Michelle's Manifesto coming at you from beautiful Bali, Indonesia. It is hot here, so I might sweat a little bit, but that's okay. I am coming at you today to talk about some very important topics like your Medicare fee-for-service acute days, your skilled nursing facility days, and levels of care. I do consider myself a Medicare queen. I am a registered nurse with a very strong background in RAC auditing, consulting, trauma nursing, sports medicine. I used to be the program director for inpatient rehab, and that meant that me and the medical director, which is usually either a physiatrist or a neurologist, we would look at patients that have had strokes, traumatic brain injuries, amputation, neurological disorders, and we would bring them into our rehab to get them to optimal level. Now, this earlier today, I did a live video, and I like to do live videos because I don't have to edit it and I can just put it out there and I have more time for my life. But unfortunately, I kept losing connection, so I decided to do a follow-up piece to reinforce. I'll still post the previous video because it's live, but this one is just going to be a recap. And what I'm sharing with you, I will also put in the description because I believe that you need to listen to what people have to say, but they need to provide you the source in which they explain that information to you. So for me, it will be Medicare.gov as well as CMS.gov. And again, I will put those descriptions in, or those links in the description, so that you can educate yourself and hopefully educate your friends or family member. So as mentioned, I have a very strong background in case management, and case managers and social workers, and sometimes a case manager is an umbrella for an RN or a social worker, okay? So, it's good to know the difference. But either way, just understand that someone is going to come in and do an assessment on you to make sure that you're prepared for discharge, okay? And some of the questions that a case manager like myself would ask is, when I come in, I want to know who you live with. And it's not that I'm trying to be nosy, I just want to know who your support system is. I'd like to know things like, how do you get around? Do you use an assistive device like a walker or a wheelchair? Are you using furniture to get from one room to another? That gives me an idea of your mobility and your endurance and your stamina. I also want to know who takes you to your appointments. I want to make sure you're getting to your appointments. I want to know where you get your medicine and if you have any issues getting those meds, because maybe I might be able to provide resources where you could get free meds or you could get discounted meds. Sometimes by using like Walmart or another service, you can actually get a 3-month supply of medicine for cheaper than what your copay is for one medicine that you're getting through your insurance plan. So there's all kinds of services and resources that are available to you, okay? I also want to know, are you eating? Can you afford to eat? Are you choosing between eating a meal or getting your medicine? Because there's also other elder care services, not just for the elderly, but for people that can't afford it, like Meals on Wheels and other resources that are available to you. Maybe food stamps, okay? And the social worker will be able to link you up with those types of resources, okay? So anyway, there's a lot to cover. I encourage you to get a pen and a paper because what I'm about to cover is very important. And I know me, I forget things. This stuff is like ingrained in my head because I've been doing it for years. I used to go into hospitals and I would teach physicians, nurses, social workers, managers, case managers, patients and family members the same information that I'm going to give to you. I think it's very important that you're well versed in what your benefit plan provides. And I am talking about an American based Medicare traditional fee for service, the Part A, the Part B, okay? There are so many other topics to cover with Medicare. I am not talking about your Medicare Advantage plans, okay? Because those require a prior authorization or permission to provide services, okay? So let's put your Humana Gold and your Medicare Advantage plans on the back burner because we're only talking about traditional fee for service, the Part A, the Part B. And just so you know, Medicare is a more powerful entity than the IRS, okay? They put physicians, providers in jail all the time for Medicare fraud, okay? So just so you know. And also, it's very important that we preserve Medicare because we're all going to need it at some point if we qualify for it. That's a whole nother piece, but just for the most important part, let's not waste, let's not defraud Medicare. That's not good, it's not good karma. And I'm coming at you from Bali, Indonesia, so there's all different types of health variations in the world. So let's specifically talk about American-based Medicare traditional fee-for-service, okay? And then today, the topics that I would like to cover are how many acute care days you get and how many skilled nursing facility days you get. Because Medicare fee-for-service has two separate buckets. One is for acute days, the other one is skilled nursing facility days. I will explain where you can use your acute days at and where you can use your skilled nursing facility days at, okay? But before we go any further, we need to understand what a Medicare benefit period means, all right? Some people are confused because they think that their Medicare benefits are based on a calendar year, okay? The enrollment piece might be, but not your benefit period. So a benefit period means the day you're admitted to the hospital or a skilled nursing facility until discharge, and when you're out of all care for 60 consecutive days or 60 days in a row. So the day you're admitted until discharge and out of all care for 60 days in a row. Let's talk about what isn't care, okay? When you think of a nursing home, you think where your grandma or family member lives, you think, oh, they're getting care. Yes, they are, but it's not considered levels of care that Medicare bills for, because Medicare is not paying for that nursing home where grandma lives. Usually that's Medicaid, some other long-term insurance, which I hardly see anymore, or it's cash. 2 or 3 years ago, average was about $8,000 to $10,000 a month. So it's very, very expensive. So even though they're getting care like feeding, toileting, grooming, they live there. So Medicare does not differentiate between a nursing home, an assisted living, or your private residence, okay? So that's out of all care, all right? Now, before we get into what levels of care are, let's talk about how many acute days and how many skilled nursing facility days you get. So like I said, traditional Medicare fee-for-service, Part A, Part B, they give two buckets. One of them is for acute days in a hospital, an LTAC, or an inpatient rehab, and the other bucket is 100 days exclusively, specifically for the skilled nursing facility, okay? Now, Medicare allows, per benefit period, we already talked about that, which I will leave a link in the description, 90 acute care days. 90 acute care days. And they also allow 60 lifetime reserve days. Now, lifetime reserve days cannot and will not ever reset, okay? Once you use those, they're gone. But those 90 acute care days can reset over and over within the year as long as you meet the Medicare benefit period, and that's you go home, a nursing home, or an assisted living for 60 days in a row, okay? So, I'm in the hospital. I have 90 acute days and 60 lifetime reserve days. I use all 90 of my acute care days and I go home and I stay out of the hospital for 60 days. I come back to the hospital, unfortunately, it happens. My 90 days that I used have automatically reset because I was out of all care for 60 days. I still have my 60 lifetime reserve days. First of all, I never touched them. Another scenario, I'm in the hospital for 100 days, okay? I use all 90 of my acute care days and I burned into 10 of my 60 lifetime reserve days. I go home out of all care. I stay out of the hospital for 59 days. I come back in. I don't have my acute care days anymore because I didn't stay out of care for 60 days. Now I only have 50 of my lifetime reserve days. Now there's a financial responsibility on the patient, which is a whole nother piece. So guess what? I now have to apply for a different insurance or work something out with the hospital, or I'm going to get a big fat bill once I burn into these 50 lifetime reserve days. Now, same scenario. I leave the hospital. I stay out of the hospital for 62 days. I come back into the hospital, and assuming that I didn't use those 50 lifetime reserve days, my 90 acute days will reset, and I still only have the 50 lifetime reserve days, okay? A lot of times when patients go into the hospital, if they are down to their reserve days, somebody from the financial team will come and talk to them, because some patients won't want to use those lifetime reserve days, okay? Because the worst case scenario, you burn through your 90 acute days and you burn through your lifetime reserve days, and you don't leave the hospital so that your acute days will reset. You now have just pretty much become a self-pay, and you're going to pay everything out of pocket if you don't qualify for Medicaid. And to qualify for Medicaid is a whole nother piece, because you have to deplete your assets down to a certain amount, and that is not cool, especially when some of you worked your whole entire lives to build up your portfolio, your checking account, your savings account, all to find out that now you're going to have to burn it for healthcare purposes, right? So it's important that you understand. All right. So Medicare allows a 90 acute care days that will reset over and over again. You cannot reset those 60 lifetime reserve days, okay? But keep in mind that that's how much you get. In the other bucket, Medicare allows 100 skilled nursing facility days per benefit period, okay? The benefit period is the same period as it was for the acute days. You go out of all care for 60 days. Now, it's very important to understand that out of those first 20 days of those 100 skilled nursing facility days, Medicare will pay the first 20 days with no financial responsibility on the patient's part. So that means they can stay at that skilled nursing facility for the first 20 days with no copper penny due. In a skilled nursing facility, you usually require services like complex wound care, you might require IV antibiotics, you might require physical therapy or occupational therapy or other services like that, okay? That can be done at a lesser level of care. So you're stabilized from the hospital, okay? And now you just need a little bit of extra care, but you're not quite ready to go home. So the skilled nursing facility would be the most important transit, or the most appropriate transition from the acute care setting, okay? Now, let's talk about levels of care, all right? All right, so the hospital is at the very top of our pyramid, the very top. They're doing ER, the OR, they have planned surgeries, they have unplanned surgeries, they've got patients that are coming in, they have had a heart attack that need aggressive care, they might have a trauma patient that just got hit by a car, a train, or a multiple vehicle collision accident. All these types of things, you just don't know, and unfortunately it happens. And what's more unfortunate is there's only so many beds inside the hospital, which is why the nursing case management department with their social worker assesses you with the doctor. There's a team that meets to make sure that you're still requiring the intensity of service and that you meet it by severity of illness. If you think of severity of illness and intensity of service, how sick are you and what do you require? That's really the easiest way to break that down. How sick are you and what do you need? Do you need the ICU where you're needing inotropic drugs or anticonvulsants or maybe ventilator support? Because we're not going to turn you away, okay? And we're not going to turn anyone away, which is why we have hallway beds and hospitals go on diversion. Diversion is where a hospital is so full that they just can't take any more patients safely. They cannot provide the safe care. So they might try to send them out. They might try to send them to a lesser level of care like an LTAC, which we'll get into. But just keep in mind, hospitals are not just trying to kick you out, people. A lot of family members think, oh, they're just trying to kick me out. No, no. It's because they need those beds. They just do. Okay? All right, so let's get back to our pyramid. Hospitals at the very top. Underneath the hospital is what's called an LTAC. It stands for long-term acute care. It is the very same as the hospital, except they don't have the ER or the OR. They have the same licensed ICU units. They can do bedside tracheotomies. They can do conscious sedation for complex wound care. They can do a lot of things. They just don't have an ER or an OR. So please don't confuse an LTAC with LTC, like the nursing home, long-term care, because the LTAC is long-term acute care. The only difference from the LTAC and the hospital is the LTAC doesn't have the inpatient, or excuse me, the OR or the ER, okay? Underneath the LTAC is what's called an inpatient rehab, which I absolutely love. I used to be the program director there. It's still acute, okay? And what this facility does is it takes in patients that may have had a stroke, a traumatic brain injury, an amputation, a hip replacement, a neurological disorder like, say, myasthenia gravis exacerbation or cerebral palsy exacerbation or something like that, okay? And that's what its job is. And there's a whole nother segment I could do on an inpatient rehab. But there are 13 approved diagnoses, and I've named some of those, and I'll also put those in the description. And to understand that the inpatient rehab is your most aggressive form of therapy. And to go to inpatient rehab, you have to require at least 2 of the 3 disciplines. So you need either PT and ST, PT or OT, or you can use all 3 of them, okay? And please do not confuse this rehab with the rehab that I'm about to explain in the skilled nursing facility, okay? Because it's far different. So the hospital, the LTAC, the long-term acute care, as well as the inpatient rehab, all pull from your acute care bucket, okay? Whereas the skilled nursing facility that's right underneath inpatient rehab pulls from those skilled days. So those skilled days are dedicated to the skilled nursing facility, also known as a SNF. Okay? So one more thing to keep in mind is a lot of times in hospitals, and this is very confusing, especially for new nurses and social workers, um, they confuse rehab with the inpatient rehab and the skilled nursing facility. And those are 2 different pots, okay? Like I said, the inpatient rehab pulls from the acute care days, the skilled nursing facility pulls from the skilled nursing bucket, okay? The inpatient rehab requires that every patient that comes in that has Medicare must do 180 minutes or 3 hours of therapy per day. It can be broken up throughout the day. It's not that you have to pound out 180 minutes all at once. It just means that you need to be able to participate in 3 hours of therapy per day from 2 of the 3 disciplines or all 3. So you could be doing 20 minutes of physical therapy, 50 minutes of occupational therapy, but it must total up to 180 days. Medicare's mandate says if a patient cannot do it or will not do it, they're out. They're out because those days pull from those acute care days. And remember, you only get 90, and those 90 have to go for a hospital, an LTAC, or an inpatient rehab. Okay? So patients that aren't able to do that full 180 minutes per day are most likely going to go to the skilled nursing facility, which breaks my heart, okay? It really does. Because if you and I were getting 180 minutes a day of therapy, we are going to be to optimal level, okay? All right? Most of us don't even work out for 3 hours a day, okay? I know I don't. But imagine if your family member was getting that full 180 minutes per day. Wow, okay? All right? Now, let's talk about what's underneath the skilled nursing, let's talk about the skilled nursing facility. So, hospital, LTAC, inpatient rehab, skilled nursing facility. The skilled nursing facility can provide therapy. They can provide all 3 disciplines. They can also provide the IV antibiotics, the wound care. But the thing to keep in mind about the skilled nursing facility is many patients go there to get stronger. Their stamina endurance is low. They laid in a bed for a week with pneumonia, so they're pretty weak. And you know, when you're in a hospital setting or a skilled nursing facility, there's always a lot going on. There's people coming into your room. There's the call bells, the neighbors snoring. They're always checking your vitals. So you don't get the sleep that you need. But unfortunately, the therapists, when they come in, they want you to do the therapy. And they understand that you're tired. But if you, in that skilled nursing facility, decide, you know what, I don't feel it. I'm not feeling it today. I'm just going to stay in bed. they'll mark that you refused. But you're burning your day, okay? And I get that you're tired, but just keep in mind that you're burning through those 100 days. And if you don't have a secondary insurance and you're still in that first 20 days, Medicare's paying that full bill as if you were participating like a champ, okay? So keep that in mind. All right. Now I want to go back over something really quick. So at the top of the pyramid, food chain of the hierarchy, and the reason why I do a pyramid is I want you to understand the hospital, the LTAC, the inpatient rehab, the skilled nursing facility, the nursing home, your home, or the assisted living, okay? And then you have what's home health. So if you're in a nursing home or assisted living or your private residence, you can get home health care, but usually early on, they're only coming in 2 to 3 times per week, if that, okay? It depends on what the insurance company will allow, all right? Based on how sick you were and what resources that you need. So in a skilled nursing facility is usually where a lot of patients go because they either didn't know about these other levels of care or they just weren't eligible for it, right? They didn't require the 2 or the 3 disciplines to go to the inpatient rehab, or they weren't acute enough because the hospital, the LTAC, and inpatient rehab are all billing from your acute care pot and those lifetime reserve days. Whereas the skilled nursing facility is a lot more lenient. You get 100 skilled nursing facility days. And so if you don't feel like doing the therapy, you know what, whatever. You're just going to take a loss and your insurance company's still going to get billed and you can still lay in the bed. But I always tell my family members and my patients, if you're too weak, right, and you're in that nursing facility and you just don't feel like doing it, you should have a good support system. And you might want to consider, if you're medically stable, to go ahead and go on home and take the advantage of home health so that you can be out of all care at least for 60 days or at least preserve those skilled nursing facility days that you have, okay? Now, as I mentioned, sometimes the inpatient rehab and the skilled nursing facility rehab gets interchangeably used. Don't confuse them because inpatient rehab, 180 minutes a day, have to do it. If you can't do it or won't do it, you're out. Whereas the skilled nursing facility, you do what you can do, which is why a majority of patients go there. All right? So that's the most important thing to know about levels of care. Now, if I have a patient who's in the hospital, in the ICU unit, now keep in mind the ER's pumping, the OR's pumping, the physical therapists are spread out between all of the patients that are in the hospital and all the unexpected ones because a lot of patients in the ER need assessments. So the physical therapists are spread out. And when you're in the acute care setting, the hospital, you're lucky to get like 20, 30 minutes of physical therapy or occupational therapy per day. And if you're in the ICU and you're on a ventilator, you're knocked out, you're either, you have a brain injury or you're in a medically induced coma and you don't have family members that are coming in and moving your arms and your legs, giving you passive range of motion, you're going to get even weaker. Unfortunately, those patients don't always get seen because the other patients are prioritized, right? So I, as an ICU critical care trauma case manager, I'm always trying to talk the doctors and family members into moving the patient to an LTAC. If they've been on a vent for 3 to 5 days, all right, we've got them medically stable. They still need the inotropic drugs, dopamine, whatever, milrinone, whatever, okay? I would love to get them to the LTAC, and it's right below the hospital. And the reason why I want them to go to the LTAC is the LTAC has no ER, no OR, which means the patients that are there are admitted. It's almost like going to college. You get accepted. They can only take in so many patients because they only have so many beds, all right? And so the physical therapist, the occupational therapist, and the speech therapist get to plan their day based on the hospital census. And since there's no ER, no OR, there's no surprise admits. That means you can do as much therapy as you can tolerate. So if you're in an ICU knocked out, those PT, OT, and ST are going to come in and do their thing, and they're fabulous at it. They're going to be moving your legs, your arms. They're going to be getting you out of bed. They're going to be doing the things that you need to have done so that you can get to optimal level faster. And those same patients that are in the LTAC, I, as an LTAC liaison, because I've been an LTAC liaison, an inpatient rehab director, and an inpatient rehab rehab liaison, I'm going to try to get those patients to inpatient rehab. Because if you've been on a vent for, say, 2 weeks or a month, I feel like, and the doctor usually agrees, let's get you to inpatient rehab and let's do 180 minutes of therapy per day. And I get real excited about that because I want you to get the most aggressive care right downhill. I don't want you to go from, unless you don't qualify for inpatient rehab, I would hate for you to go from hospital down to skilled nursing facility unless you only required minimal services. But if you're really sick and you had a stroke or you have had some type of medically induced coma that required ventilation support, I'm going to try to get you to the LTAC. And then from there, I'm going to try to get you to inpatient rehab because I want you to get the most aggressive care for those 90 days without hopefully burning into those 60 lifetime reserve days. But if we have to burn into them, then you just do. You just do. And there's specialized people inside the hospital that will help you qualify for other insurances if need be. Okay? There's always different moving parts at the same time looking at you to see what does this person qualify for. Because unfortunately, folks, healthcare is a business. We don't have universal healthcare like other countries do, all right? It's a business, all right? It just is. And I have worked with many trauma surgeons where I would literally say to them, we need to get this patient to an LTAC. And usually the patients that they don't want to let go of are ones that require complex GI surgeries because they're very protective. They want to do those surgeries. And I get it. I get it. And of course, if you need a surgery like that, you're not going to go to an LTAC unless that surgery needs to happen later on. Like you need to get to a more healthier state or optimal level before they can even perform those surgeries, okay? But I, as an aggressive case manager, trauma case manager, and I've worked with some world-renowned trauma surgeons, okay? I would trust them with my life. I would tell some of these same surgeons, hey, we've got to get this patient to an LTAC, right? Some of these patients didn't require surgery, but they were just really sick on the vent. And they'd be like, no, 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 we'll talk about it tomorrow. And I'd be like, but we're burning through their days. Oh, no, no, Michelle, it's okay. Guess what? Once we burned through their days, I couldn't get them accepted because the LTAC has to be able to bill those Medicare days. And guess what? They burned through them. Or maybe they only had 20 left and the LTAC knew, hey, we're going to need at least 30 days. I mean, who knows? But they don't want to get stuck with trying to find the patient another insurance. They want to focus on getting that patient to optimal level. So it's very important that you know that those days, once they burn up and you don't go out of all care for 60 days, you are now a self-pay unless you qualify for another insurance, which is why I always poked and prodded my trauma surgeons, hey, we have to consider an LTAC. We just must. And it's not that I want to kick you out. I just want you to get that same aggressive support. A pulmonologist will manage your vents. Infectious disease is there in case you catch a bug. A fully licensed ICU. And then you've got the disciplines, PT, OT, ST, while you're knocked out, that are moving and shucking and jiving to get you to optimal level. Because they then will try to discharge you to the inpatient rehab or the skilled nursing facility, depending on what it was that you needed. Okay? So that's the reason why you guys need to know this when you go to the hospital. Because if you don't know it and nobody tells you, or your case manager didn't know it, because you don't know what you don't know. That's why I'm spending my time explaining this to you. And I will leave links in the description so that you can look at it, you can sit on the toilet, you can reread this stuff, because I'm not making this up. This all comes from Medicare.gov or CMS, okay? And remember, Medicare is more powerful than the IRS. So just a quick recap. Medicare, acute care, which qualifies hospital, inpatient, or hospital, LTAC, inpatient rehab, all pull from your 90 acute days and those 60 lifetime reserve days. The skilled nursing facility that's right underneath inpatient rehab has 100 days per benefit period dedicated for skilled nursing facilities. And to have both sets of those days, you have to go out of all care for 60 days in a row. And out of all care means a nursing home, not skilled nursing facility, because Medicare does not pay for nursing homes. Nursing home, assisted living, or your private residence. All right? So I know that was a whole lot to take in. please leave any comments that you have in the comment box. If you want to discuss other things like inpatient versus OBS, because I am going to do a whole different piece on that, because that's another important topic to know. Because some of you think just because you're in observation status that you're an inpatient, and you're not. It looks the same from the outside, but you're not, because Part A pays for your inpatient and Part B pays for those OPS services. It's just like you were going out getting x-rays or labs. You're still going to pay for that stuff just like you did on an outpatient basis. Okay? And again, we'll talk about those things. I don't want to overwhelm you. I just want you to understand what we talked about today, which are your acute care days, the 90, the 60 lifetime reserve, your skilled nursing facility days, which were 100. They reset when you're out of all care for 60 days. And then, of course, we talked about the pyramid, the hospitals at the top. The LTAC is right below, same as the hospital, no ER, no OR, same license ICU. Right below the LTAC is inpatient rehab, requires 3 hours of therapy a day. 2 of the 3 disciplines, or all 3, for things like stroke, traumatic brain injury, neurological disorders, burns, amputations. Underneath the inpatient rehab is the skilled nursing facility. Could require some IV antibiotics, could require some therapies. But I tell you, if anybody brings up skilled nursing facility, ask your doctor if my family member or yourself qualifies for inpatient rehab, because that is your most aggressive therapy and it's going to get you home quicker. Okay? And remember, those top 3 bill from the 90 acute days. The skilled nursing facility is only those 100 days. All right? And out of all care is the nursing home. Even though you're getting care there, it's toileting, grooming. It's not that aggressive PT and OT that we need to get stronger. Remember that. And remember, share this information. Be very well versed with Medicare.gov, which I will leave a link in the description. And thank you so much for joining my channel. I get really passionate about Medicare because I love it, and I love you all. And I'm wishing all of you health, wealth, and longevity. But I also want to educate you and inform you so that you can make the best decision that'll get you to optimal level and get you as the most strongest way you can. I mean, I'm 50 plus and I work every single day because I don't want to have to go to these facilities. But if I do, you can bet your ass I'm going to understand those benefits. And when those doctors come in and say, hey, we think you should go there, we think you should go there, you know what? I think this is where I should go, because you are the most important team player in your healthcare plan. Suksama for joining my channel. Thank you so much. Please don't forget to subscribe. I will talk about whatever it is you want to talk about. Anytime you want to talk about it, just leave it in the comment box. Thank you so much.